Welcome to Learning Thursdays. I'm Dean Hale with the OASAS Learning and Development Unit and your host for today's presentation. Today's presentation is titled Plans of Safe Care, Developing Plans of Safe Care with a Patient-Centered Approach, and our presenter is Dr. Ramsey, Chief of Medical Services at New York State OASAS. She will be joining us in just a moment. First, a word about Learning Thursdays. Learning Thursdays are offered to behavioral health professionals as a free learning opportunity with the goal of improving the knowledge and skills of the New York State substance use disorder workforce as we strive to improve the lives of individuals needing prevention, treatment, and recovery services. A goal of Learning Thursdays is to support the professional development of the treatment, prevention, and recovery workforce. We do this by offering regular presentations that are relevant to today's substance use disorder treatment professional. As always, if there are any questions, comments, or suggestions, please feel free to contact us at the Learning Thursdays mailbox. You can use the same mailbox to express an interest in providing a future Learning Thursday program. And now it's time to start the presentation and welcome Dr. Ramsey.
Thanks, Dean. So today we're going to talk about plans of safe care. So let's go over the learning objectives first. Explain to providers how to develop plans of safe care, identify the steps to creating adequate plans of safe care, assess plans of safe care that patients may have already worked to develop, and discuss ways to connect with substance use providers and other community providers to support patients at discharge. So first, I'm going to give a little bit of background information to support providers in developing plans of safe care and help providers to understand the patient population that we'll be discussing. So this is not the first time we've had an opioid epidemic among women in the United States. So actually, the first surviving records of opioid use disorder, which was formerly called at that time opium addiction, date from the end of the 18th century. Morphine was initially isolated in 1804, heroin was synthesized in 1874, and there was also development of the hypodermic needle, and dependence to these opioids became more common after they were commercially produced. Throughout the 1900s, both opioids, so essentially opium, heroin, or morphine products, and coca, or cocaine-based products, were marketed as unregulated medicinal tonics for use, particularly with women and children, for common maladies. For example, opioid products were prescribed for cough, and cocaine products were prescribed for fatigue. Doctors at that time commonly prescribed opiates, so again, heroin or morphine, for middle and upper class white women for things such as nervousness and female problems. An increase in the incidence of opioid use disorder among women was noted as early as the 19th century. However, at that time, infants were not thought to be affected because it was believed that morphine use or heroin use among women was associated with sterility and loss of sexual desire. Obviously, we know that this is not true. So this fallacy was corrected with the first reported case of an affected neonate with opioid withdrawal at birth in 1875. At that time, they labeled it congenital morphinism, and they did not know how to treat it, and the baby died. In 1903, the first infant with congenital morphinism, or what we now call neonatal opioid withdrawal syndrome, survived after being treated with morphine, which is the primary treatment that's used in treating infants with NOWs today. So let's talk about the opioid epidemic currently and some of the statistics. So first, let's look at overdose deaths by gender. On the left-hand side, you see the last formal data that we have, which is from 2019. The 2020 data is still provisional, and we don't have that final data yet. So these are age-adjusted drug overdose death rates by gender in the United States between 1999 and 2019. You can see that there are more total deaths in males than in females, but in both males and females that the number of opioid deaths is increasing. On the right-hand side is looking at the increase in opioid overdose deaths among U.S. women aged 30 to 64 years old. And you can see that whichever category of opioids that we are looking at, whether it's prescription opioids, synthetic opioids, or heroin, that the numbers have increased between 2007 and 2017, particularly with respect to synthetic opioids. This is looking at, again, 2019 data at opioid misuse among women, and you can see that the most frequently using group with respect to opioid misuse is the group of 18 to 25-year-olds. These two graphics are looking at substance use and mental health issues in women. On the left-hand side is looking at polysubstance use and mental health issues. So you can see that with respect to whichever type of substance use we're talking about, whether it's marijuana use or alcohol use or cocaine use, if a person has a history of opioid misuse in the past year, then there is increased use of other substances as well, whether it's marijuana, heavy alcohol use, cocaine, methamphetamine use. And also more commonly with a history of past year opioid use, you have more women with mental health diagnoses such as major depression or serious mental illness. On the right-hand side, again, looking at co-occurring use and mental health, you can see that if someone is diagnosed with either any mental illness or a serious mental illness, they're more likely to be using all substances. This slide is looking at mental health and substance use disorder among women, and it's looking at the high prevalence of both mental health diagnoses as well as substance use disorder diagnoses. However, there are large gaps in people accessing treatment. With respect to any mental illness in those that are 18 years old and above, about 50% of persons do not ever receive any treatment for their mental health. With respect to substance use disorder, the numbers are even more stark. Only about 11% of persons ever receive any treatment for their substance use disorder in the group 12 years old and above. Looking more specifically at pregnancy, on the left-hand side, you can see that the number of admissions of persons who are pregnant who are using marijuana have increased pretty progressively over time since the early 1990s. And on the right-hand side, opioid use disorder specifically has risen 4 times among pregnant persons between 1999 and 2014. These two graphics are both depicting the similar data about the prevalence of opioid use disorder per 1,000 delivery hospitalizations. So you can see that the prevalence of opioid use disorder on the left-hand graphic has increased pretty continuously since about 2000. And if we look on the right-hand side, it is a breakdown by state, looking at states with the highest prevalence of opioid use disorder, again, among pregnant persons who are admitted to a hospital for delivery. And the states in darkest blue color are the states with the highest prevalence. So New York is not one of the states with the highest prevalence. However, obviously, we want to be aware of what's going on in our own state as well as other states with higher prevalence. This slide is looking specifically at substance use among pregnant persons. On the left-hand side is looking at past month substance use, and this again is data through 2019. So you can see that the most commonly used illicit substance is actually marijuana more than any other. However, this also shows use of tobacco and alcohol, which are more prevalent than the use of any illicit drugs. On the right-hand side is looking at marijuana use by pregnancy status. So with pregnant persons, the percentage of marijuana smokers has gone up and down over time, but you can see among the non-pregnant person population, the use of marijuana has consistently risen over time. So the graphic on the left here is showing us what sort of naturally occurs when persons discover that they are pregnant who have been using substances. So substance use actually normally progressively decreases during pregnancy, increasingly by trimester. So in other words, people who may be using alcohol or cigarettes or illicit substances when they are not aware that they're pregnant. When they discover that they are pregnant during each trimester, they typically use less and less. So how do you tease out substance use versus substance use disorder in pregnant persons? The vast majority of pregnant persons are motivated to maximize their own health and the health of their developing fetus. So those pregnant persons who can't cut back or quit using likely have a substance use disorder. Continued use in pregnancy could indicate a substance use disorder. This slide is looking at substance use disorder treatment during pregnancy. So as I mentioned previously, most persons in general with a substance use disorder do not receive treatment for their substance use disorder, and that applies to pregnant persons as well. So as you can see here, the number of persons who actually receive treatment, who need treatment, is higher in the pregnant person population than in the not pregnant person population. However, as you can see, the percentages overall are low in both categories. So how about some more background information about persons with substance use disorder in pregnancy? So there's commonly co-occurrence with mental health issues. So 2/3 of persons who are pregnant and have substance use disorder also have a co-occurring mental health diagnosis. Most commonly, that's major depression, generalized anxiety disorder, or PTSD. The majority of pregnant persons with substance use disorder have a history of childhood trauma, particularly pre-adolescent sexual or physical trauma. And there's also a high level of intimate partner violence in the last year. With respect to reproductive health issues, most of these pregnancies are unplanned, about 80%. There are often low rates of contraception use among women who are actively using drugs. I think of it as contraception and thinking about preventing pregnancy just falls pretty low on the hierarchy of needs with someone who's actively using. With respect to other substance use, as I mentioned, polysubstance use is common, but actually the most common other use substance is tobacco with rates of greater than 90%. And then with respect to social functioning, there are often deficits there. There are often inadequate social support, social isolation, and exposure to poor parenting models, or another way of saying that is lack of exposure to good parenting models previously. Let's talk a moment about maternal mortality in the United States. So unfortunately, in contrast to most other developed nations in the world, the rate of maternal mortality has been increasing in the United States. You can see the trend on the left-hand side graphic that the US has a completely different trend than all the other countries listed. On the right-hand side, again, it's reinforcing that point that maternal mortality, which I should define that for everyone, that is death of the pregnant person during the pregnancy or up to 1 year postpartum. So again, unfortunately, the United States leads with respect to the rate of maternal mortality compared to other industrialized countries. This is specifically looking at maternal mortality due to fatal overdose, which is a rising cause of death for maternal mortality in the United States. So this is specific to Massachusetts. So this is looking at overdose in persons who have delivered who have opioid use disorder. So you can see that the rates of opioid-related overdose are lowest in the second and third trimester. And then in the third trimester to 6 weeks postpartum, opioid-related overdoses increase fourfold. So these are particularly vulnerable time periods for pregnant persons or persons who have delivered and are early in the postpartum period, that often the stressors of having a new infant lead people to resume use who may not have tolerance to opioids, either because they're not on medication for opioid use disorder, for instance, or they're using another substance such as a stimulant and they have no tolerance for opioids. So particularly vulnerable during this time period. And then opioid-related overdose is actually highest 6 to 12 months postpartum. So again, is that due to decreased tolerance, or is it because they are not using medication for opioid use disorders such as methadone or buprenorphine? I think it's always important to address stigma when we're talking about pregnant and parenting persons. Unfortunately, there's unsurpassed stigma towards persons in these categories compared to often other persons who use drugs. So these are just some news headlines: pill popping mamas, many pregnant women take opioids, CDC finds, and number of mothers using opioids while pregnant is rising in Tennessee. So just a reminder that language matters. When we use bad language, this perpetuates stigma. So we need to always be using person-first language. So be describing people as a person with a substance use disorder, a person with opioid use disorder, not referring to people as an addict or a substance abuser or an alcoholic, et cetera. And the other term I'm just going to focus on is clean or dirty. We should not be using those terms ever in the context of either describing persons or their time when they are using or not using, or with respect to their toxicology results. We don't use those terms to refer to any other persons with a chronic disease, and we should not be using them with respect to persons with substance use disorder. So there's often a misrepresentation of neonatal opioid withdrawal syndrome, or NOWS, in the popular press. Such inflammatory phrases such as newborn's death sentence and addicted baby are inappropriate and are not accurate and should not be used. And unfortunately, a lot of the press pits the parent versus the child rather than seeing the birth parent and the child as a dyad that should be supported together. And stigma is not benign. Stigma leads to dehumanization, which leads to discrimination and prejudice, and ultimately to punishment of pregnant persons who use drugs. Unfortunately, there's wide variability of state policies on substance use during pregnancy in the United States. 23 states and the District of Columbia consider substance use during pregnancy to be child abuse under civil child welfare statutes, and 3 consider it grounds for civil commitment, which means that a pregnant person who uses drugs could be incarcerated against her will and removing her civil liberties for the duration of a pregnancy. 24 states in the District of Columbia require healthcare professionals to report suspected prenatal drug use, and 8 states require them to test for prenatal drug exposure if they suspect drug use. 19 states have either created or funded drug treatment programs specifically targeted to pregnant persons, which is a good thing, and 17 states in the District of Columbia provide pregnant persons with priority access to state-funded drug treatment programs. And 10 states prohibit publicly funded drug treatment programs from discriminating against pregnant persons. So unfortunately, you can see that more states have discriminatory policies than have supportive policies. So just to let people know what the rules are in New York State, and any other state that has SAPT block grant funding, they are required to have admission preference for pregnant persons. So on the left-hand side, you can see the hierarchy of priorities for admission to treatment programs. So pregnant persons who inject substances are first priority. Pregnant persons with substance use disorders, generally speaking, are second priority. Individuals who inject substances are third priority, and all others are fourth priority. And on the right-hand side, again, just reinforcing the language with respect to the block grant funding. So treatment providers must ensure timely access to treatment services for pregnant persons. If a treatment provider is contacted by an applicant regarding admission via telephone or in person, program staff must inquire if the prospective client is pregnant, and if so, the provider must prioritize an evaluation of the individual as urgently as possible and determine the appropriate level of care for the individual. The provider shall prioritize the admission of the pregnant person and act with urgency to admit them unless the person requires a service not offered by that provider. In that case, the program staff should determine whether an appropriate treatment referral can be found using the Find Addiction Treatment website, or contact their local provider network and/or their local government unit to determine the availability of treatment in order to refer the applicant to a provider that can best meet their needs. So punishment of pregnant persons, is this utilizing best practices? And I would argue that it is not. It's discriminatory. So persons of color and poor persons are more likely to be prosecuted despite white persons being more likely to use during pregnancy. It is not evidence-based. The risks of illicit substances are often exaggerated in comparison to the risks of legal substances, such as alcohol and tobacco. It has unintended consequences. So punitive policies drive pregnant persons away from both substance use disorder treatment and prenatal care. And it hinders engagement. So prenatal care actually counteracts the adverse effects of substance use during pregnancy. So if you have policies that discourage engagement in general, including in prenatal care, then obviously that's going to cause worse effects with respect to the pregnancy, both for the birth parents' outcomes as well as the neonates' outcomes. So this comes from ASAM, the American Society of Addiction Medicine, on stigma and engagement, or lack thereof, in prenatal care. This is a little bit of a wordy quote, but I think it's worthwhile to read it. Research has identified the stigma around neonatal opioid withdrawal syndrome and substance use disorders in general as a significant barrier to treatment for pregnant persons. Many pregnant persons do not self-disclose their drug use during pregnancy due to stigma, complicating the treatment process. In addition, when they do reach out for help, they often encounter misinformation, denial, inaction, and even judgmental and punitive attitudes towards their substance use. In some cases, policies that initiate punitive responses to pregnant persons with substance use disorders may also create barriers to treatment. In 2013, 40 leading medical experts sent a letter to several prominent news outlets describing how sensationalized terminology commonly used in the media to describe NOWs is medically inaccurate and reinforces stigma. Drug-addicted babies, for example, is not an accurate description of babies born with NOWs. These newborns may exhibit physiologic dependence, but they cannot exhibit the compulsive behaviors associated with addictive disorders. This language is successful at eliciting a strong emotional response, but may also help to reinforce many of the negative attitudes that discourage pregnant persons from accessing the treatment they need. So as I mentioned, when pregnant persons engage in prenatal care, even if they're actively using substances, it can mitigate some of the negative outcomes that could occur from substance use itself. So here, if we compare a person who is not using drugs but not engaged in prenatal care, they have 19% of their births are associated with low birth weight. However, if we look at a person who is actively using drugs and engaged in prenatal care, their outcome is the same. About 19% of their babies will have low birth weight. So as you can see, even though they're actively using, it mitigates the effect of that on low birth weight by being engaged in prenatal care. The worst outcome is when someone is actively using and not engaged in prenatal care, when 48% of the infants that they give birth to have low birth weight. So the next slide looks at the cost of the opioid epidemic, and this goes through 2020, but I wanted to point out the two largest costs of the opioid epidemic are lost productivity due to both fatal and non-fatal overdose. However, another significant portion goes to child and family assistance, again, with the involvement of the child welfare system with the families who have substance use. So because of that and the cost to the system, and the cost not only financially, but the cost emotionally and in inflicting trauma within families with substance use disorder, it's important that we understand how best to support families with substance use disorder. So let's look at some of the components of patient-centered and family-centered care. On the left-hand side, we see a graphic that is looking at patient-centered care with the pregnant person or the person who just delivered, the infant and family in the center. That family requires a lot of care coordination and trauma-informed care across multiple domains. So that includes medication for opioid use disorder or for other medications for addiction treatment and substance use disorder services, as well as physical health services, which could include the OBGYN for prenatal care or include a primary care provider, et cetera. Mental health services where applicable. It may involve parenting and child development, child welfare, other supportive services such as community care management or healthy families or a public health nurse in the community, and it may very well involve the criminal justice system. It's important that we think about supporting that pregnant person and that family and that infant over the continuum, so not only during the pregnancy and at the time of birth, but also prior to the pregnancy and also after that first year of the postpartum period. And on the right-hand side, we're looking at family-centered care. So what are some of the components of family-centered care? It could include decision-making, which may be with multiple persons in the family. There may be information-seeking components, care burden and family resilience, needs of other siblings in the family, siblings of the infant, parental stress, cultural and spiritual care, differing parenting styles, quality of life, and social supports. So how do we create a plan of safe care with a patient-centered and family-centered approach? First of all, what is it? What is a plan of safe care? A plan of safe care is a document which identifies how a provider, family, and community can support the safety and well-being of the infant and the person who gave birth. How do I make it person-centered and family-centered? A plan of safe care should be individualized and should address basic needs, identify current supports, and anticipate future needs and coordinate supports, and include other resources and community-based supports, such as I mentioned on the previous slide. So therefore, knowing a patient and their individual needs is imperative to creating an effective and actionable plan. Who can create a plan of safe care? Any healthcare provider or social services provider can develop a plan of safe care in collaboration with a pregnant person. Ideally, this would be done prenatally and with an anticipatory lens for needs postpartum and shared with the hospital or birthing center. However, if a plan of safe care is not done prenatally and is required at delivery, then the hospital or birth center should ensure that the person who gave birth has a warm handoff in the community to necessary supports to create a plan of safe care. OASAS does have an LSB on the plan of safe care at the website listed. Just please note that we will be revising that in the near future, so check back frequently. Who needs a plan of safe care? So pregnant individuals who are diagnosed with a substance use disorder or are receiving medication for addiction treatment for a substance use disorder or are under the care and supervision of a healthcare provider that has prescribed opioids require a plan of safe care. What is the purpose of the plan of safe care? It is a tool that can be used to support families impacted by substance use or taking medications to treat substance use disorder. The purpose of the plan of safe care is to ensure that families are receiving comprehensive support, care, and treatment to meet their individualized needs. Remember, substance use and/or substance use disorder in and of itself is not an indicator of child abuse or child maltreatment or child neglect. So let's try to understand the steps in creating adequate plans of safe care. So New York State has not yet released their implementation documents for plans of safe care. So the documents that I'm using in this PowerPoint are actually pulled from New Hampshire, but very soon, New York State will be releasing these documents. It was a collaborative effort between the New York State Department of Health, OASAS, and OCFS to create those documents. So hopefully within the next 1 to 2 months, that will be posted on the Department of Health website. So let's just talk about an overview of the plan of safe care process. So is the infant affected by prenatal drug and or alcohol exposure? So if the answer is no, then no plan of safe care is required by law. But it is best practice to develop plans of safe care for all birth parents and their infants. So is the infant affected by prenatal drug and or alcohol exposure? Yes. So that is when a plan of safe care must be developed and is a mandatory report made. So that would depend, again, on the specific circumstances at the time of birth. So if a mandatory report is not made, and we'll talk about that, the details of that in a few minutes, then the plan of safe care is just sent home with the birth parent at discharge, or the plan of safe care is going to be developed by a warm handoff with a referral from the hospital or birthing center. If a mandatory report does need to be made, then the plan of safe care is sent to OCFS or the local CPS, and also with the birthing parent upon discharge. So what can we do to create a framework to support pregnant persons, families, and infants? How can we engage pregnant persons in a collaborative process to plan for healthy outcomes? How can we work with existing supports and coordinate new services to help infants and families stay safe and connected? And how can plans of safe care support pregnant persons and their infants during pregnancy, delivery, safe transition home, and in parenting? So the overarching goal is family-centered care, plan development, and implementation. So some of the things to take into consideration are patient, family, and care provider collaboration, consideration of family context. Obviously, each family context is unique, and have dedicated policies and procedures at your organization in order to create plans of safe care. And then also be sure to reference illness-specific education that's appropriate for that particular birthing parent, infant, or family. So when is a plan of safe care developed with the pregnant person? A plan of safe care must be developed when an infant is born identified as being affected by substance use or withdrawal symptoms resulting from prenatal drug exposure or fetal alcohol spectrum disorder. So again, it is affected, not exposed. That's the distinction on when a plan of safe care must be developed. However, best practices support developing a plan of safe care prenatally to serve as a living document throughout the pregnancy and after birth, especially when there is a risk of prenatal exposure to substance use. And what is the purpose, again, of a plan of safe care? For the parents and the infant, the safety and well-being of the family, to address health and substance use treatment needs, to make appropriate referrals and deliver appropriate multidisciplinary healthcare and social services. And a plan of safe care must account for whether the infant's prenatal exposure is due to a prescribed medication, or whether the person who gave birth is or will be actively engaged in treatment upon discharge. So again, some best practices for this process, and I have modified New Hampshire's process. So first, notify. So notify public health of the birth of exposed and affected infants as requested on the birth certificate. Develop plans of safe care with all pregnant persons and or caregivers early in pregnancy. Provide a copy of the plan of safe care to the person who gave birth and the infant's primary care provider upon hospital discharge. Coordinate the parents' referrals and access to appropriate supports and services. Submit the plan of safe care to CPS or OCFS when a report of child abuse or neglect is made. Include the plan of safe care in information provided to parent supports and services as authorized. Be sure to include the parent and have them sign a 42 CFR Part 2 consent form if the plan of safe care includes any information around substance use, substance use disorder, or substance use disorder treatment. So how do you engage your patient prenatally in a plan of safe care? I think it's a good idea if your organization creates a pamphlet describing to pregnant persons what the plan of safe care is and what the purpose of it is. It can be very potentially scary for patients to disclose their substance use or their substance use disorder and have that listed on a plan of safe care. So it's important that they understand, again, that the plan of safe care is intended to protect them, and that the plan of safe care does not need to be shared with CPS unless there were a case of neglect or abuse or maltreatment, which again, substance use in and of itself is not an indication for child abuse or neglect. So this is an example of the New Hampshire pamphlet that they created for plans of safe care. So what are possible components to consider in a plan of safe care? There are a lot of components that can be included, and here are just some examples, and this is not an exhaustive list. So you should include demographic information about the parents, other caregivers, healthcare providers such as the OBGYN provider, a primary care provider, a pediatrician, and a medication for addiction treatment provider, other friends, family, or community supports, social service providers, household members, and emergency contacts, current supports and services for the birthing parent, new referrals needed for services, so either current needs or anticipated needs at delivery, and then linkages with those services prenatally or postnatally, strengths and goals for the pregnant parenting person and for the newborn, the patient's thoughts about the plan of safe care, having the patient sign a 42 CFR Part 2 consent as applicable, so that the plan of safe care can be shared and discussed with other healthcare providers and social services providers participating in their care, and encourage patients to discuss their plan of safe care with important persons involved in their lives, their community, and their care. So what are some potential needs to consider in the plan of safe care? Breastfeeding support, medication for addiction treatment, peer and recovery support, counseling and/or mental health support, vocational training or support in finding employment, housing assistance, educational support, parenting skills training and/or support, family resources and support, health insurance, WIC, safe sleep education or planning, childcare, home visiting services, family planning or birth control, financial assistance or temporary assistance, smoking cessation or no smoke exposure education, transportation, legal assistance, car seat or additional infant supplies, domestic violence or intimate partner violence resources, and primary care provider information. For example, if the patient does not have a primary care provider, providing a warm linkage to one. As I mentioned, this is not an exhaustive list, but it gives you an idea of what potential things to include in a plan of safe care. So how to assess if a plan of safe care that patients may have already worked to develop is adequate or not? So does the patient's plan of safe care need anything added to it? Does the plan include all significant parties in the patient's life? Is the information on the plan of safe care still current? Does the plan incorporate current needs and services utilized? Is the infant and his or her needs and needed referrals included in the plan of safe care? Have new needs arisen that were not previously identified in the plan of safe care? Are new referrals needed? Has a warm handoff been arranged? Does the patient know whom to contact if things don't go as planned? Have we done everything possible to best support this parent, this family, and this infant? So let's try to assess a plan of safe care in given scenarios. In this scenario, the plan of safe care was developed prenatally. So the plan of safe care was developed prenatally, a consent was signed prenatally, and the plan of safe care is part of the electronic medical record or the patient's chart that is sent to the hospital or birthing center. At delivery, the plan of safe care is incorporated into the discharge plan for the parent and infant. Obviously, that is the ideal scenario. So now let's look at assessing the plan of safe care when it has not been developed prenatally. So the plan of safe care was not developed prenatally. At delivery, therefore, there is no plan of safe care. Facilitate a warm linkage with a community-based provider to create a plan of safe care for the person who gave birth and the infant. Who in the community can develop a plan of safe care with the patient? A care manager, someone who has a case act, a primary care provider, a medication for addiction treatment provider, a social worker, a doula, a visiting nurse, a public health nurse, a discharge planner, etc. So how can we connect with substance use and other community providers to support patients at discharge? So pregnant persons with substance use disorder have a unique set of needs across multiple domains, and these are domains that affect both obstetric health and outcomes and substance use disorder treatment and outcomes. So care needs to address all those complex needs, ideally are co-located integrated services. So how do we identify substance use disorder during pregnancy? So the recommendation is universal screening, not risk-based screening. So identifying at-risk persons early, utilizing motivational interviewing, normalizing questions and embedding them into an electronic medical record. When I say universal screening, I'm talking about using validated screening tools, and these are verbal screening tools. I am not talking about urine toxicology. Some of the validated screening tools that could be considered are the DAST, the MAST, 4Ps Plus is specific for pregnancy, and CRAFT is specific for adolescents. Urine toxicology is not recommended for screening for myriad reasons. It has a short detection window, confirmation testing is required, it may not capture intermittent or binge use, or it may capture one-time use. And there are ethical issues. If a urine toxicology is medically indicated, then informed consent must be done with the patient before taking a urine toxicology. Otherwise, it is unethical to take a urine toxicology. There are also patient and provider barriers to screening. Patients have fear of discrimination, mistreatment, and sometimes inappropriate referrals to CPS. Providers often have a lack of training, time, and knowledge, particularly on how to address positive test results. So what is the standard of care for the treatment of opioid use disorder during pregnancy and postpartum? So medication for addiction treatment with either methadone or buprenorphine is standard of care for the treatment of opioid use and or opioid use disorder during pregnancy. Pregnant persons do not need to meet DSM-5 criteria for opioid use disorder to receive medication for addiction treatment. They just need to be using opioids. So medication for addiction treatment during pregnancy is endorsed by the CDC, WHO, SAMHSA, ACOG, ASAM, AAFP, AAP, essentially all professional medical organizations. And access to behavioral counseling as an adjunctive treatment if needed. So either the medication for addiction treatment provider or staff, or by referral to mental health or an SUD treatment program, such as an OASAS program or a dual diagnosis program, if needed. Again, it should be adjunctive. There should be no coerced behavioral counseling. Just a reminder about what is called the fourth trimester, and we're talking about that vulnerable postpartum period. So first of all, it's a reality check. So caring for a newborn can be challenging. There can be breastfeeding issues. There can be bonding issues. There's also a lot going on with respect to mood changes, sleep disturbance, and other physiologic changes after delivery. And then there's the challenge of cultural norms. In society in general in the United States, there's pressure to be the ideal parent. But again, the scrutiny on pregnant persons or postpartum persons who use drugs or have a history of a substance use disorder is unparalleled. And then there can be social isolation and minimal social support. And often CPS is involved, sometimes inappropriately involved. There's also less focus on the person who gave birth. So there's a shift of attention from the parent, prenatal care, to the baby, pediatric care. 40% of persons who give birth miss their postpartum visit, and that data comes from ACOG, or the American College of Obstetrics and Gynecology. Care often shifts to social service agencies, such as WIC, and often the medication for addiction treatment provider is the only continuity of care for that parent. And also, don't forget to address contraception with patients. Often there's an unintended, unplanned pregnancy that follows shortly after a person has given birth. So remember to discuss long-acting reversible contraception with patients. From the ACOG community opinion paper, here is a quote on opioid use and opioid use disorder in pregnancy. It is important to advocate for this often marginalized group, pregnant persons with opioid use disorder, of patients, particularly in terms of working to improve availability of treatment and to ensure that pregnant persons with opioid use disorder who seek prenatal care are not criminalized. Finally, obstetric care providers have an ethical responsibility to their pregnant and parenting patients with substance use disorder to discourage the separation of parents from their children solely based on substance use disorder, either suspected or confirmed. So just a reminder of some of the things that should be addressed in a visit if your patient is actively using or known to have substance use disorder. So ask about their substance use, normalize this. People are more likely to disclose about their substance use if asking is a normal part of practice. Assess risk for overdose. Dispense or prescribe naloxone regardless of substance use disorder diagnosis or intended drug of choice. This is because of the ubiquity of fentanyl or fentanyl analogs added to the illicit substance supply. Assess the person's need for PEP, post-exposure prophylaxis, or PrEP, pre-exposure prophylaxis, to prevent HIV. Initiate it or refer for services. Vaccinate for hepatitis A, B, tetanus, etc., and either give these vaccines or refer for services. Test and treat for hepatitis C and HIV and link to care. Dispense the prescribed condoms or other birth control as needed. Refer to syringe service programs or prescribe needles and syringes, or give a warm handoff with a specific referral. So, for example, give a brochure with specific location and hours of programs. Make a safety plan, counsel on not using alone because of the risk of unintended overdose. Counsel on medication for addiction treatment to decrease the risk of overdose. So counter any voiced internalized stigma that the patient states by addressing medication for addiction treatment information with facts. Address any other acute needs of the patient, and above all, listen and be non-judgmental. This is the New York State Department of Health guidance document called Build a Safety Plan, which is a great document to go over with anyone who's actively using, again, regardless of what substance they're using. So where should I refer patients? So the ideal scenario is a patient comes with a plan of safe care and already is linked with community supports, and the patient continues that care. What about if the patient is actively using and needs harm reduction services? So locate local syringe exchange or syringe service programs. You can do that by contacting the Harm Reduction Coalition at the website that's listed, or the New York State Department of Health Office of Drug Use or Health. So what about if the patient has a substance use disorder and is interested in substance use disorder treatment? So you can contact OASAS. We have a Hope line that has an 877 number, or you can text, or you can go online at the website listed. So the treatment facility locator allows individuals to search by region for gender-specific programs with a family-centered focus that allow kids to accompany parents into care. Or if you have difficulty finding a program, you can always contact the OASAS Ombudsman Program, and the CHAMP hotline is listed there, or you can email at the email address listed. What about if the patient has opioid use disorder and is interested in primary care-based buprenorphine treatment? So you can utilize the SAMHSA buprenorphine practitioner locator. Unfortunately, there's no completely comprehensive centralized database for locating a buprenorphine provider in the community, but you can certainly start with the buprenorphine practitioner locator. And what about if a patient is interested in support from a certified peer recovery advocate? You can contact OASAS at the information on the previous slide. What about if the patient has mental health issues and is interested in engagement and services? So you can contact OMH. Probably contacting your local OMH field office would be the best way to access that information, or you can go to that website. Remember, it's always better to provide a warm handoff with a name and an appointment, and preferably direct contact between the patient and the referral rather than just a list of names and numbers. So let's talk about some conclusions on developing plans of safe care with a patient-centered approach. To develop an effective plan of safe care, it is important that we understand the patient population of persons who use drugs and the stigma they face in the healthcare system. Ideally, plans of safe care are developed prenatally with the pregnant person's input and acts as a living document throughout the pregnancy. Engagement in prenatal care improves outcomes regardless of substance use or engagement in substance use disorder treatment. Decreasing stigma increases engagement in care. Pregnant persons with substance use disorder experience discrimination and scrutiny on an unparalleled level. Care ideally is co-located, multidisciplinary, non-judgmental, and patient-centered. If care is not co-located, a warm handoff facilitates care engagement. The intention of the plan of safe care is to identify how a provider, family, and community can support the safety and well-being of the infant and the person who gave birth. Remember, substance use and/or substance use disorder in and of itself is not an indicator of child abuse or child maltreatment or child neglect. Lastly, I just want to talk a little bit about how we can develop a more comprehensive healthcare approach for pregnant and parenting persons. To do that, we need structural level changes, and we need supportive policies that provide reimbursement for comprehensive services, access to appropriate identification, assessment, and treatment for substance use disorder across the lifespan, not just during pregnancy, access to whole body, whole person healthcare, so avoiding compartmentalization, responsible safe prescribing by medical providers and training on substance use disorder diagnosis and treatment for medical providers, tobacco cessation support, and now hospital policies and protocols that support the parent-child dyad staying together and avoiding unnecessary and unnecessarily long NICU stays. The Pregnancy and Substance Use Harm Reduction Toolkit is an excellent resource for people to be aware of. And you can find that online at the National Harm Reduction Coalition website, and that is a free toolkit that you can download. SAMHSA also has a clinical guidance document for treating pregnant and parenting persons with opioid use disorder and their infants, and that can also be found free on the SAMHSA website. If you have any questions, please feel free to reach out to me directly at my email listed here. And I thank you again for your time and attention to this important topic.
I want to thank our presenter, Dr. Ramsey, for today's program. I hope you will all find it useful while assisting clients in needs of services. Your feedback is important to us. It helps us to know if we're meeting your educational goals and expectations. Once you have viewed the presentation in its entirety and completed the quiz, please follow directions to access the SurveyMonkey website and take a moment to complete the evaluation. Once again, thank you for joining us and keep up the good work.